So we'll be starting today. Today we are talking about urethral dilation. So yes, obviously you are yet to kind of start with your residency, but still, I mean, it's good that you're attending. And I hope these are helping you a bit. And any suggestions you have, any particular topics you want us to cover, please do kind of write to me or maybe the support team or something, and we'll definitely try to incorporate those particular topics as well. Okay? Right. So let's start with urethral dilation. Okay, now obviously you have not joined your residency, you have not seen these particular patients, but whatever the theoretical knowledge you have, what do you think? Like, who are the patients who might need a urethral dilation? Like, what is the condition which comes to your mind for the treatment of which we will do a urethral dilation?
Maybe any urethral stricture or so.
Good, urethral stricture, or maybe a meatal stenosis. Okay, so yeah,
Meatal stenosis, yes.
stenosis or a urethral dilation. We like urethral stricture. We will have to do a urethral dilation. Okay, so first, what we are going to do, we are going to understand the dimensions of the urethra. Now, the urethra in the males and the females is different, right? I mean, the length is different and the caliber is different. The sphincters are different. All those particular things are different. Okay, so let's try to understand this first. So urethral dimensions, the normal urethra measures 30 French. Okay, so the diameter is around 30 French. Obviously, it varies from the different parts. The meatus is the narrowest part. Then we have the bulbar urethra, which is basically the widest part of that. Okay, and its dimension is approximately 10 millimeters. That's fine. The calculated luminal area is around 78 millimeters square. That's all fine. Nothing major about this. So why all these particular things are important? Because this is what the god has made. Okay, but it doesn't mean that if the diameter reduces even by a bit, patients will be very symptomatic. No, it doesn't happen. Okay, so let's try to see when do the symptoms start in a patient. Okay, so if the scarring has resulted into the urethra, that measures 15 French. Okay, so what do you think? Like, if at all the urethral dimension from 30 French had reduced down to like 15 French, what should happen to the lumen? Okay, what should happen to the lumen? The lumen is still 55
No.
millimeters square.
Okay.
And there is only 29% reduction. You understand my point? So there is 29% reduction in this particular lumen. Okay. Just YT is trying to admit. Okay, that's fine. Okay. Right. So what you need to understand is that whenever we do, let's say, a urethroplasty, okay, or whenever we treat a urethral stricture, we have to be realistic. We cannot aim for the 30 French urethra. We don't. Even if we are able to achieve, let's say, 14 French caliber, we are good enough. Okay, so why 14 French? Because normally we have the catheters of 14 and the 16 and like, or like the even numbers, and we need to calibrate. Okay, so even if we are able to have a Qmax of, let's say, 10, 11, and even if the diameter is, let's say, around 14 French, we are okay with it. We don't try to kind of achieve it to the 30 French or something like that. So this is something which is important. So obviously this is the basics of the anatomy which you need to understand. So we have a meatus, then we have this particular navicular fossa, then we have a penile urethra, we have a bulbar urethra, then we have this external sphincter, which is surrounding the membranous urethra. Here we have a urogenital diaphragm, then we have a prostatic urethra, and then we have an internal sphincter. So this is what you refer to as the basics of the normal anatomy of the urethra. So are you able to appreciate that the urethra is a bit S-shaped? Are you able to appreciate this?
Yes, sir.
Okay, so the normal urethra is a bit S-shaped. Okay, so this will basically tell us when we use the S-shaped dilators in order to dilate this. Nowadays, what we use is a serial dilation. That is what is something which should be used, the serial dilation in the form of an S shape. So we'll talk about that. Okay, right. So in this, you just appreciate that the normal urethra is slightly S-shaped. Okay, it is slightly S-shaped. Okay, now urethral dilation is the oldest and the simplest treatment of the urethral stricture, may be curative in the epithelial strictures without spongiofibrosis. Okay, so if I ask you, define a urethral stricture. So what is the definition of a urethral stricture?
Sir, I would just say that basically narrowing, which will cause enough symptoms for the patient for him to come to us.
No. So what you need to understand is that the definition of a urethral stricture is obviously there is a urethral narrowing along with Spongiofibrosis. Spongiofibrosis. Okay, so we say that the patient is suffering from urethral stricture if these two things are coexisting with each other. Now, what do you understand with the spongiofibrosis? So, what you need to understand is that we have a corpora cavernosa, we have two corpora cavernosa, and we have one corpora spongiosum. Okay, yes, obviously, right? We have three cylinders inside in the cross section of the penis, right? Two corpora cavernosa and one corpora spongiosum. Corpora cavernosa are the ones which have the blood sinusoid. So if at all there is an increased flow of the blood in these corpora cavernosas, we get an erection. Okay. What about the spongiosum? In the corpora spongiosum, like that is something which is surrounding the urethra. Okay, so urethra basically goes through the corpora spongiosum, and the corpora cavernosa have the blood. So whenever we have erection, there's an increased flow in the corpora cavernosa. So everybody understood? Like, oh, I hope you have understood. Right now, in order to say that the patient is suffering from a what you call as a urethral stricture, the patient should have a urethral narrowing along with along with what you refer to as your spongiofibrosis. Okay, understood? You have any doubt?
No, sir, clear, sir. Yes.
Now, uh, do you feel that do we have a posterior urethral strictures? Is there something which is called as a posterior urethral stricture?
Yes, sir, we can have, like when we have injuries about, like when we look at membranous urethral rupture, at that point of time, we can have membranous urethral structure.
So that's what you need to understand. What is this? This blue colored thing, are you able to appreciate the blue color? That is what is a corpora spongiosum. Understandable? Yes?
Yes.
Okay. This is what is your urethra. This is the penile urethra. This is the bulbar urethra. This is the membranous urethra. Are you able to appreciate that the spongiosum is ending over here? Do we have spongiosum in this part? No, we don't have spongiosum in this part. Are you understanding my point? Here
Yes, sir.
we have a prostate gland. Here we have a urogenital diaphragm. The spongiosum ends over here. So, what did I tell you? What is the definition of a urethral stricture? Urethral narrowing with spongiofibrosis. Okay. Do we have a corpora spongiosa surrounding the posterior urethra? No,
No, sir.
we don't. So, posterior urethral stricture is a wrong terminology. We never ever use it. Are you understanding my point?
Yes, sir.
Okay. So, what do we use for it? Have you ever heard of PFUI or PFUID? PFUDI, whatever, distraction injury. Okay. So, the terminology which we use for that is pelvic fracture urethral injury. So, most of the posterior urethral injuries are associated with the pelvic fracture. So, we do not have a posterior urethral stricture. What we have is a pelvic fracture urethral injury. Did I make some sense to you? Did you understand this?
Yes, sir, I understood this.
Okay, right? So there's no posterior stricture. So this is the oldest and the simplest treatment, that's fine. May be curative for the epithelial strictures without the spongiofibrosis. So in those patients in whom the spongiofibrosis is not very much, in those particular patients, if you just do a urethral dilation, maybe that is going to help the patients on a long-term basis. But in those patients in whom the spongiofibrosis is quite severe, in them, urethral dilation is something which is not going to be used. Are you understanding my point? Or obviously, for the time being, it will give some relief to the patient, but there will be very, very high rate of recurrence of the urethral stricture in these patients. Okay, got it?
Yes, sir.
Okay.
Yes.
Now, whenever we perform a urethral dilation, what is our goal? Our goal is to stretch the stricture. Our goal is not to tear the stricture. Okay, so our goal is to stretch the scar without producing more scarring. So, if at all there is a narrowing, if at all there is a ring, we want to stretch it. If we tear it, what is going to happen? Again, the fibrosis is going to happen, and now the next time when the after the fibrosis, whatever the scar is going to get formed, that is going to be even more tougher. Okay, are you understanding my point? So that is what you need to understand. So whenever we are dilating any particular patient, our aim is to just stretch the scar. We are not aiming to kind of tear the scar, because after tearing, again the healing process is going to happen, and now when the fibrosis happens, that is going to be even more tougher. Okay, and that is the most common mistake which most of the even the urologists and